Welcome everyone. This is Dr. Jaitly, your cardiologist from New York, on your favorite website, MuniMeterHealth.com, which is dedicated to teaching you about the human heart and its illnesses. And here we are once again wanting to acknowledge you deeply. Our thanks and gratitude for associating with us on our two social media channels. Obviously, we are featuring primarily our clinical education, and of course, we are also emphasizing the patient education as well, because these two really determine the clinical outcomes, as we have talked about, and that's been my initiative over the past 35 to 40 years as a cardiologist. So I really want to enhance all of this through my video format now over the past several videos that are compiling into my library here. So hope you're enjoying each one of them, and each video vignette is only roughly about 10 to 12 minutes. Obviously, we try to cover one disease entity or one illness entity and try to cover that as much as possible. Mainly it's for interns, residents, fellows, and the exam-going medical students, I always say. So this way they can quickly brush up their skills. Obviously, it's not a replacement or substitute to your text, so I do recommend that go read back your texts, but this is a great supplement though. So it's not a substitute, but it's a supplement to your text. Now, having defined that, I just want to make sure if somebody's having an emergency, obviously go back and see your hospital, go to see a doctor or call for an ambulance, but this is just a teaching advice video format or a tool that we are offering. Now, without any further ado, I'd like to delve into the subject matter. The matter of the subject here is what is sarcoidosis? I'm sure you've heard that before. And what are the cardiovascular manifestations? Obviously, we like to see what the clinical features of the cardiovascular part will be like. Well, primarily, first of all, let's understand what the etiology is. The etiology is unknown here. So that's easy, right? No. Well, there are some hypotheses that people are working on. One, we know that there are some HLA haptens, if you will, and these are partial antigens where there might be some autoimmune phenomenon that may be existing. We don't know yet, but that means there's some genetic clustering, if you will, and that have been defined. So there is some evidence of genetic clustering. People have talked about occupational, exposure or work-related, etc. So we don't know yet, but there might be some suggestions there. So having defined, then there's been some mycobacterium etiology that has been suggested, and again putting question marks here because we do not know what the hypothesis is, but there's numerous etiologies here. Now, normally it manifests in the third or the fourth decade, so 30 to 40 years of age, and again there's no gender bias, but predominantly it's been shown to occur in it's a slightly higher incidence in Scandinavian countries, in the Europe, and in US it's about 10 to 40 per 100,000 population. Japan notably has more cardiac manifestations, if you will, and cardiomyopathies, if you will. So Japan's sarcoidosis is a little more specific, just remember that. And we don't know why, but that's maybe one of the genetic clustering, or maybe it's the environment there, etc., etc. So that's still under investigation. But Japan sarcoidosis tend to have more cardiomyopathies. Okay, and African American as well as Hispanics, they tend to have multi-system involvement. So just so that you know, so the African American and the Hispanics will have more multi-organ, if you will. Okay, so these are some of the characteristics of sarcoids, if you will, that we can define right now. Clinical features. Now, what are the organs affected? Obviously, one, skin and skin sarcoidosis, uvea or the eyes. Renal involvement can occur, and we know about the cardiac. So here we'll just try to discuss quickly the cardiac manifestations. The cardiac manifestations primarily are conduction abnormalities. Remember that. Conduction abnormalities are the most important ones, and that might be a question on the boards, directly and indirectly talking about sarcoid, and they might give you a Quime test, they might give you some lymph nodes on the chest x-ray to suggestive, or they might say that this patient responded very well to steroids and the conduction abnormalities disappeared, or what have you. So there might be a question or two on that relation. Myocardial infiltrates, and they tend to have progressed to fibrosis, if you will. And when they progress to fibrosis, obviously, this becomes more arrhythmogenic. So this is arrhythmia-prone area. So just remember that. So a lot of conduction abnormalities can exist. So those obviously will be bradyarrhythmic. This will be tachyarrhythmic, and a lot of VPCs and APCs and VTACs can occur as well in sarcoid settings because of the myocardial. And then cardiomyopathy we always talk about because the pump failure in general is much less than conduction abnormalities and the myocardial infiltrates that one sees. Okay, so having defined an ischemia, etc., those things do not occur, so you don't have to worry about that part. And here we are back on the screen again. Okay, so diagnosis is usually by suspicion, but then one can see the pulmonary nodules, for instance, and of course patients will show ACE levels. Again, they do not corroborate they're not proportional to the sarcoid activity. Now just remember that there's a thing called acute sarcoid, and acute sarcoid normally is also called Lofgren syndrome, and that's normally again present in Scandinavians, and so that can manifest in an acute type of a systemic reaction where there might be fever, loss of weight, and dyspnea, and then of course some increasing eye problems and upper extremity claudications because of vasculitis, etc., etc. All these things can occur. Treatment classically is corticosteroids, and that works wonderful. And in fact, some of these patients can go into remission, and as soon as you try to sort of taper down the steroids, they go back into a relapse. So just remember that many times steroids can be continued forever, or at least on a maintenance dosages to prevent any remission. So prevent any relapses rather. So they can stay in remission based on the steroids. And that's where we are pretty much with sarcoid. So just remember, conduction abnormalities sometimes requiring pacemakers. You may end up giving a pacemaker in these patients. Now, briefly, I just wanted to give you a quick schematic here. And the schematic where the conduction abnormalities normally exist, they are somewhere here. If you look at, this is the aorta offshoot here. We divide that into the aortic valves. Here is your left anterior descending, left circumflex goes around like that, and right coronary travels like this. And these are the various vessels, which obviously will intermingle and branch off and form collaterals here. So, but the conduction abnormality, if you were to look at, that will go somewhere here, the interior of the heart, and this is your SA node, this is your AV node, and it is this place, this is where the conduction abnormalities will exist, and so also within the bundle branches here, because this is where the His bundle and then the bundle branches are sending the impulses upwards in this direction. So invariably what happens is you either have a block, so one can see on an EKG a left anterior hemi block, so ECG may show some first degree AV block, for instance, can show second degree AV block, which could be Mobitz 2, or it could be Wenckebach, or it could be a third degree AV block, which is complete heart block, and we call that. So just remember that these are mindful of these things, because on the ECG, these may be one of the clues that could lead you to the diagnosis of sarcoidosis. Okay, but as I said, the myocardial infiltrates will obviously lead more to ventricular arrhythmias, and scars can ensue. Cardiomyopathies is pump failure is much rarer in these individuals, but in general, it is the conduction abnormalities which really take the highest incidence of cardiac manifestations. Okay, thank you for watching MuniMeterHealth.com. This is your quick video vignette on sarcoid and its cardiovascular manifestations. And as I said, it's not such a rare entity, but still one does see in practice a few times a year. And then when you follow these cases, they do very well on steroids. And there might be some familial clustering, so it's a good idea to invite the rest of the family, siblings, etc., to come back and get them examined, etc., etc. And these are some of your highlights of cardiovascular manifestations on sarcoid. So I thank you for your interest, and continue following us on MuniMeterHealth.com. More exciting stuff coming down the line. So long. Bye.